sustainable implementation. So to move or to really continue this positive momentum, we see that a lot of countries are implementing these solutions. More and more devices get connected. The GLI started and launched a task force on diagnostic connectivity in the beginning of this year, really to keep this positive momentum going in this rapidly developed field. Together with several agencies, technical partners and donors, several focus areas have been identified of where this task force will try to give support to. One of the most important things is to help countries and programs to select appropriate solutions and select appropriate hardware. One of the things is that to keep the comparison table up to date and also adding hardware solutions to that comparison table so that there's one overview of all the different solutions. As well as helping to define best practices in data usage and data agreements. Those are difficult contracts and difficult agreements, and we try to leverage our common knowledge and our common experience to come up with the best approaches for this. As well as providing guidance to countries on how you can best link patients and diagnostic solutions and diagnostic data within the whole program to have a patient-centered approach. And what really helps is to build capacity and help countries to build in-country capacity on the utilization of data. So what kind of approaches can we build on, and what kind of approaches can we provide? And when we work together with different partners and different donor and technical agencies, it's also important to coordinate whatever each partner is doing and what is happening in each and every country, as well as facilitate the evidence on the utility and the impact of diagnostic connectivity solutions. So today, in this symposium, after this brief introduction, Patricia Campbell will show more about what is that diagnostic data that's being collected on these devices and how can we best use it. And then an approach for the practical and applicable use of data will be presented by Mo Tobin. And we have some more time to also engage ourselves with this approach because one of our speakers is unfortunately unable to come. But we will close our session with one of the new technologies and one of the new devices that will be coming. And we'll certainly present a new era for diagnostic connectivity because it's the first device in the TB sphere that has inbuilt connectivity. So thank you very much. The GLI quick guide is still available, as well as the comparison table, and I think there are also some printed versions for everyone who would like to see it. And by this I would like to go back to.
All right, so I think for the sake of time, we're going to try to keep the majority of the Q&A to the end. But if there are any clarifying, what they call burning questions that you can't hold on to, Christian will take that right now. All right, window closed. All right, so I'm going to introduce our next speaker. Dr. Patricia Campbell is a microbiologist with the International Lab Branch, with the Global HIV and TB Division and Center for Global Health at the US CDC. She's going to present, like Christian mentioned, on how NTPs, NTRLs, and Ministry of Health staff can better utilize the data that's currently being captured by those diagnostic tools.
Thank you, Kaiser. Let's see. Okay, so I'm going to provide a kind of broad overview of diagnostic data using connectivity solutions. What can we collect and how can we use it? Because I think that as Christian has mentioned, there's a wide breadth of data available and it's not always utilized to the full potential, and so I want to kind of give you just a general landscape of what the potential that's out there. So we all know that data is essential for continuous quality improvement of diagnostic networks. This goes from the baseline, if you start with the blue arrow, from analysis and understanding of a current situation, to then, that can then inform planning and modeling of your actions that you then implement, monitor, and evaluate and revise in a kind of iterative process. And continuous quality improvement, utilizing network data, utilizing epidemiological data, can really be used by TB control programs, specifically to improve patient identification and treatment, disease surveillance, including outbreak investigations, policy guidance as well, including diagnostic algorithms, where that falls under the National TB Program. It can be used to continuously improve TB laboratories, again, the testing algorithms that are utilized, monitored and implemented, the performance of testing as well as the quality, and TB logistic services. So this covers everything from procurement and supply chain management, as well as sample transport and referral networks where relevant. So diagnostic connectivity solutions, I think their main power is in automating the data reporting process. Excuse me. Where traditionally, data that's generated at the site level here has to be reported and recorded using various forms and registers, paper tools. This is a manual-based process from the site level up to a regional supervisory lab, up to the central level. This could be the national program, the Ministry of Health, to various stakeholders at the national level in order for them to provide supervision and guidance to the levels below. But this data also has to be transmitted to clinicians and, most importantly, patients. This is a time-consuming process. It leads to a lot of long turnaround times. There are data quality challenges, and so the ability of these connectivity solutions to transmit data in real time to multiple user groups up the chain and also down to patients is really invaluable. And so this is such an important tool that it is now included by the WHO as a core indicator for lab strengthening under the NTB strategy. So in 2016, WHO set the target for connectivity. They have now set this as 100% of rapid testing sites within the TB space need to transmit electronically to programs and clinicians by 2020. In April of 2017, to support this goal, in part, as Christian mentioned, the GLI published their Diagnostic Connectivity Quick Guide. And then in May 2017, I just wanted to add on a little bit of data here. We at the International Laboratory Branch at CDC completed a GeneXpert inventory that included about over 1,400 GeneXpert instruments across 25 PEPFAR-supported countries. And what we learned was that of the instruments that were reported, approximately 54% were reported as having a diagnostic connectivity solution installed. So in order to reach this goal by 2020, we still have a good bit of work to do. And installed doesn't necessarily mean functional, and it doesn't necessarily mean that it's being utilized either. So those are kind of add-on components to these targets. Okay, so what can we collect? The answer, in short, is a lot. There is a lot of information that can be collected and a lot of data variables that are collected simply by utilization of these instruments and some manual input from users. So what I'm showing here is different, user groups, from national TB programs to supervisory TB laboratories, again, the procurement and supply chain authorities and clinicians and patients, along with types of data that are cross-cutting between these users. And so starting with test result data, this is your positive, negative, RIF resistant, RIF susceptible, indeterminate. This is also utilization rates, error rates, failure rates, everything that comes along with the test itself. There's also device data. Is it functional? How long has it been reporting? How long has it not been reporting? Is a module down? When is its calibration due? How is it performing in general, which is particularly of interest to the manufacturers and some of the software solution companies. And then commodity data as well. Where are your cartridges? Are the cartridges expiring? A lot of investments are going into the procurement and implementation and utilization of reagents and this equipment that's deployed into the field. So managing all of this across a widely diverse network is challenging, particularly with the rapid scale-up and expansion of these GeneXpert networks across countries and across regions. And lastly, service data. So this is things like estimated calibration dates in the future, which ones need to have a module replaced or swapped, which ones need service visits. And you can see that some of these user groups can utilize all of these different types of information, and really probably should, right, in order to optimally monitor their network. Whereas others, such as clinicians and patients, don't necessarily need to know all of the service data on the instruments, but they do need to know if it's functional, right? So I've been kind of sneaky here. 2 of these arrows go just marginally into this blue zone because clinicians and their decision on ordering a test can be impacted if they know or don't know if an instrument is available or if it's functional. Similar with commodity data. If they send patients or specimens for testing and they get information back that there aren't any cartridges on hand at that particular laboratory, they're more likely to refer somewhere else or to not refer or refer for a different test. So this does still impact patient outcomes. Okay, so if we focus on national TB programs first, in order to continuously improve the quality of programs, I've included here on the right the diagnostic cascade. And I know that the text is a bit small, particularly for those of you at the back. This starts at symptom identification, goes towards specimen collection, specimen transport. Then we have the diagnostic component of the cascade, which is the laboratory testing in the middle. Result transmission and treatment initiation at the end. And although diagnostic connectivity solutions are only seen as providing diagnostic test data, for the blue component here, it still impacts the turnaround times, the result and reporting, and patient management and treatment decisions further down the cascade, which is well within the purview of national TB programs. So this data from a larger perspective, can help continuously improve the quality of national strategic plans, right? Network structure and optimization. How well is your network functioning today? What do you want that to look like in the future? And what kind of phased plan do you need to get there? That's part of the understanding the current situation through a gap analysis in order to modify and improve through implementation. Diagnostic cascade gap analyses. Again, are the tests being done, but they're not being reported in your case notification system? Where are the gaps happening? And budget and grants preparation, particularly through commodity management. TB disease and outbreak surveillance can be informed by this data, particularly through the real-time transmission of disease and test result information. National programs now have the power to see if you have multiple drug resistance cases coming in from a certain facility, from within a certain region, whether or not they're connected, are they HIV positive? There's all kinds of disaggregation that can be done and follow-up. TB case detection and treatment. This is kind of the perhaps more obvious one. Drug susceptibility results. These can be disaggregated by age, by gender, by key populations, such as HIV positivity, as well as potential integration with case management information systems, which is something that Christian mentioned. So if you can get this data to integrate with your notification system, and then you have a complete profile through the use of unique IDs, ideally, you can look across your patient, your current case management system and see proportion of bacteriologically confirmed patients, which tests are being used, adherence to your policies and national algorithms, for example. And lastly, patient access to rapid diagnostic services. So we all want to improve patient access to services, particularly for key populations. And this, if you combine this diagnostic data with subnational disease burden data, then you have a better picture of what populations are being served by your current network structure, which ones have access to testing services that are functional at any given time, and which ones are having to be referred or where adjustments are having to be made within the system. And again, a diagnostic algorithm performance, which is incredibly important component in today's world where the algorithms are changing so rapidly, and the policies, particularly surrounding the use of expert MTB-RIF, are also changing. Okay, so if we go to TB laboratory networks, I intentionally specified in my earlier slides TB supervisory labs as opposed to a national TB lab because there are different levels of supervision within the laboratory network. In an ideal world, those different levels of supervision from the national lab down to regional, state, district, county labs would have access to these solutions in order to monitor the areas that they are responsible for and that they normally monitor through routine and paper-based methodologies. However, we see that that's not always the case. So how can this data be used to improve the quality of national labs? Instead of national strategic plans, national laboratory strategic plans. This data can be used to inform the future plans, phase, scale-up, and development, as well as to monitor diagnostic algorithm adherence. Again, which patients are receiving expert MTB-RIF according to your actual data set versus what the algorithm is telling you. And if those two data sets are not aligning, then what kind of interventions need to be put into place to close that gap and ensure that patients are receiving the appropriate test according to national policy? Device functionality. This is getting at the basics of utilization. Are the instruments being utilized? We all know that GeneXpert instruments themselves are expanding at a rapid rate. Some countries are having over 100 instruments per year. Adding on to their networks, being distributed throughout the country. Maintenance of that network is a bit challenging, but when you add more testing capacity, you often see utilization rates decrease because you're kind of diluting out the testing need between facilities. However, you still want to see your capacity meeting what you perceive to be your demand based on the data that you have in country, and that's something that this data can help inform. Failure rates, again for quality monitoring, instrument downtime, and service status. When it comes to testing quality, monitoring error rates, and then following up with corrective actions, which is another key component, is kind of a priority and is something that you can get in real time through these solutions. So what is the error code itself? Does it indicate a potential error with the device, with the module, with the tester? You can know that from the code itself, and then you can disaggregate these by tester, by site. If it's a tester-specific challenge, is that something that maybe you need to go in and perform refresher training for a particular site or a particular set of personnel? Error codes themselves, again, and then calibration status as well to ensure that the instruments are calibrated and functioning optimally. And then lastly, again, this should look familiar, patient access to rapid TB diagnostic services through that combination of subnational disease burden information, if available at a regional level, if available to the laboratory staff, as well as laboratory testing data. Okay, so moving on to procurement and supply chains. This data can be used for continuous quality improvement of procurement processes. You can get not just your testing volumes that you can disaggregate by site, by region, and of course nationally, but you also get consumption rates. You can get that for a particular site, you can get it for a region, you can get it for the whole country. You can look at expiration rates as well. How much loss are you incurring per region, per site, and what needs to occur in order to minimize that and to include that as a factor for future procurement processes. Failure rates as well. And then commodity management. Of the stock that you have in country, you can look at stock availability. How much stock is present at a particular site, again in a particular region, and what is the expiry date and the life of that stock at each facility. This can facilitate stock transfer between sites. If you know that you have stock that's expiring at one site and another with low stock amounts or that with a higher burn rate, then that's a potential to move that stock over. And lastly, stock arrival and distribution dates. These are manual entry components, so I just want to stop and kind of note that as we go through, that some of these variables that you're going to get from your diagnostic connectivity solutions are automatic. Things like when you scan a cartridge, you're going to get the type of test, you're going to get the date and the timestamp that it was actually put into the instrument, you're going to get the result automatically transmitted. But if you want commodity management features, typically this is something that's going to have to be entered by someone into the system at the national level to say, okay, this is how much stock I have that arrived in country today, and here's how I'm distributing it to the sites. The sites can then log on and confirm or deny that that is actually the case. They can provide updates in real time, and so this allows for kind of a real-time conversation to happen back and forth without the need for paper reporting systems or parallel systems that might take longer. Service and maintenance as well. For reporting for error and failure rates again, instrument downtime, calibration scheduling. We all know that calibration is a challenge, particularly with these kind of diverse networks spread out geographically. So this can help with planning of regional calibrations, for example, based on funding availability. If you know when your calibration needs to occur for certain facilities, then you can map that out and be more efficient in your use of funds. And service agreement status as well. So these solutions will tell you which instruments have service agreements or warranties that are about to expire, how far out they are, and you can actually go through and align them based on date of service agreement as well in order to create some disaggregated reports. Sample transport. So there's a session about this tomorrow as well, all about sample transport. So I'm not going to go into it in too much detail here, but it is possible for these solutions to start to get into this space, looking at specimen referral based on instrument or reagent availability, since they have this information available and they also have the means to communicate with sites and potentially with clinical partners. And the transport network for optimization. If you're going to design an optimal transport network, then ideally you want to know your testing capacity at your different sites, your volumes, and the locations of all of the sites as to how far and what the conditions are between them. Lastly, patient management, last but not least. These solutions have the ability not just to communicate within a program, but also to get the word out on the test results to clinicians and to patients, which is important, right, for turnaround times. These can automate notification of standardized messaging for test results. And having clinicians receive standard reports and announcements without modification or additional comments is something that can be really important for clinician interpretation. So even though these are short, programs can customize these. This is a customizable feature. So it's something that you can set up to go to, for example, a clinician and an SMS reporter at a facility. Or you can send the test result to the clinician, but then have the patient notified that their result is in without providing them with a specific positive or negative that may cause confusion through an SMS. This can decrease time to reporting. This is something that's currently difficult to track. Because you know when you send the message, and ideally you know when the patient is put on treatment and therefore notified to the program, but the impact of these automated notifications on that process is a little bit harder to currently measure, but still important. You don't have to wait for the lab to print out the report off the instrument, get it back to the facility, have someone find the clinician in order to call the patient and go out into the community. These are instantaneous solutions. And then treatment initiation. Because the GeneXperts, in particular, NextPert MTB RIF, has the potential to inform RIF resistance, you can get more appropriate treatment initiation more quickly. Okay, so lastly, I just want to go over some known barriers to the optimal use of these connectivity solutions. So in our experience and experience of others and having these conversations with our country partners, these are some factors that come up and that we see that prevent these connectivity solutions from having the greatest impact that they could have on both patients and programs. The first is restricted user access. I mentioned this for laboratory systems. There are a variety of countries that provide terminals to access their connectivity solution for the National TB Program, for perhaps a quality manager, and also for the National TB Reference Laboratory without providing state-level personnel who have the responsibility to directly supervise the laboratories below them with any access at all. So they're not seeing any of this information unless they're provided with a quarterly report, for example. So that can really limit the utility of the data. Irregular monitoring. We know of some settings where perhaps people sign in if they think there's a problem, if they're alerted that there's a problem, through different reporting streams, through manual reporting streams, or they access the connectivity solution to put together their quarterly reports or their annual reports for WHO as a way of kind of data mining after the fact. But ideally, these solutions are in place in order to be able to monitor the data that's coming in and provide perhaps not instantaneous, but timely corrective actions to the gaps that are identified. It's not helpful to identify an error code if you then don't follow up on what the error code means and ensure that the problem is fixed. Limited scope of application. So there are settings where the connectivity solutions are utilized regularly, but they're only looking at, for example, test result information, or only the national program has access to it and they're only using it for commodity management because that's what they see as the greatest benefit to them. Undefined roles and responsibilities. This is a really important one because sometimes the people who are making the decision about the procurement of this technology and the installation of it are not the same people who need to be monitoring it and providing corrective actions. But unless that conversation is had up front and people understand whose job it is to monitor this, who's going to monitor which components of it, and who is going to follow up on the findings of it, it's very unclear. Which brings us to our next one, unclear follow-up procedures. So you identify the error code. Who do you call? What do you do? Is it your job? Is it someone else's job? Do you call the facility directly? Lack of corrective actions, I think we've covered, and incomplete data entry. As I mentioned, some of these fields are manual entry fields. And the power of data is only usable and harnessable when we have the data. So if people aren't filling in, for example, gender information when they do the testing or commodity information when they receive their shipments, then there's no way to utilize that in order to improve programs. So how can we address some of this? Training and sensitization. This goes all the way from the initial selection of the connectivity solution from those procuring and implementing it in country, as Christian mentioned, down to technical training on the use of the connectivity solution, how to use it most efficiently for the user group that is being targeted. Stakeholder engagement, again, to define these roles and responsibilities. Similar to that, SOP development, so that some of these workflows can be defined. It's got a clear structure to it, and you know how this connectivity solution is going to be implemented and who's going to be doing what. How are you going to monitor it? Once you have it in place, it's a really good idea to build a monitoring and evaluation framework around these. So you're not just looking at key indicators that you can get on your test utilization rates, but you're also looking at the quality of data that you're getting out of the machine. There's a way to make a more comprehensive monitoring and evaluation framework that can then be implemented and reviewed to really ensure that you're getting the most out of these connectivity solutions moving forward. And so lastly, these can really be used to optimize both laboratory and clinical services, to improve access to services, quality of testing, uptake of results, and patient and program impact. And so that's it. Thank you. I'd like to thank the following people.
Thanks, Patricia. I think for the sake of time, we're going to move on to Dr. Mo Tobin. So Mo is a consultant at the Connectivity Revolution, and he'll present his experiences in Myanmar and his approach of FIND on building capacity to better utilize the data that's being collected through these connectivity solutions.
Oh, look, that's come up. Hi there, everyone. My name's Mo Tobin. I'm working with FIND in the connectivity team. I'd like to thank the GLI for giving me the opportunity to speak and also for their ongoing support. I'd also like to thank Patricia for a fantastic presentation there and a very detailed, comprehensive view of the value that we can get from connected data. And I think a lot of the things here will resonate with things that you've said. One of the things we've seen over the last few years is the emergence of what I would call mature connected services. So by that I mean connected services that have gone through their proof of concept stages, they've gone through feasibility, have been implemented at scale, and have been running for a period of time. So these mature services have been collecting large amounts of data. And one of the many challenges that they face, beyond operating and maintaining connectivity services, is really around making the most use out of the data that is brought in. And we've seen in the last presentation how incredibly valuable this data can be. So the real challenge that I think we're all facing is, are we getting the most out of this data? Are we using it? If we're not using it, why not? And there's a plethora of reasons why that may be. So I was given a personal challenge in this space by my boss, who likes to challenge me on a regular basis. And what he's asked for from me is a repeatable process for delivering an approach to looking at data utilization and considering really how to measure it and then put in place interventions that are going to drive up the data usage and improve the quality of these systems in any given situation. So this is something that we can repeat in our own projects, but also that's something we hopefully can pass out to the community so that people can do this for themselves. So what I want to talk you through in this presentation is our approach that we've developed. We're developing this in real time on a couple of projects in Mozambique and another one in Myanmar. And one of the things that we've arrived at is a visualization to try and declutter some of the issues that you're faced with. When you start to look at these situations, it can become quite overwhelming, the number of variables and the number of issues you have to deal with. So we've developed a visualization, and we'll talk about the experiences that come from that. Okay, yes, I work for Fine Connectivity team, and there's a quick definition of connectivity that I think matches what Christian was saying right at the beginning of this session. So let's have a look at the key elements of this approach. There are only three. I'm a big believer in entity modeling. If you're presented with a problem space, the first thing you do is you capture all the entities that are involved in that. And so here, this is people, processes, resources, any entity that forms a landscape. So in our approach, the first thing we do is scope the landscape, looking at the country, disease instruments that are being used. It's quite easy to just look at the data set and not really tie down in any particular situation what you're dealing with. And it's incredible when you look at data sets, you don't need many data points to build incredibly rich and powerful services. But it's very important to understand the scope of what you're working with, the participating systems, and particularly also the stakeholders that are involved. When we think about data, we split our thoughts into two. So there's data quality and data usage. So if we start with data quality, the elements that we've defined that make up data quality are completeness. Are you getting all the data that's out there? If you have 1,000 devices and 800 are reporting, then you have a shortfall. Also, when it comes to manually entered data, of course, is that data being entered? How much of it is missing? Accuracy. We haven't really seen situations where the result is inaccurate, but an interesting example of inaccuracy could be one we've seen in HIV, where the timestamp from the machine has been set back in history, so this will allow cartridges that have expired to then still be used. So the timestamp is completely inaccurate. However, if you're looking at that data and you're monitoring it and reviewing it, you can see this bad practice, you can do something about it. Timeliness, I think, yes, how long do you have to wait for the data to arrive? Sometimes it can take weeks. So if you're reporting on the volumes of data in a day, you may have to wait a week or even a month before you have an accurate view of that. Cleanliness, availability, relevance, I think we can see the elements there. So if we then think about the data usage, now we're thinking about people process. I think we can see in here that, first of all, people generally, when it comes to actioning data, you start with working with an interface. So we catalog them, we write them down. Those interfaces can be electronic in terms of dashboards. and user interfaces on various systems, but they also consist of alerts, notifications, weekly, monthly reports that people work with. So we need to do an inventory of those and understand what they are so that we can map them and the data that's in them to the stakeholders that should be using them. Also, as we go through this process cascade, what we're really looking at is an issue of empowerment. Are the individuals who are responsible, or we believe should be responsible for actioning data, are they really empowered to do so? Those come down to the issues, a lot of them that Patricia was mentioning about training, access to the systems that they need, and also the motivation. Are individuals actually motivated correctly in order to perform these corrective actions? I've included that feedback loop in there that talks about continuous improvement. That's a process that sits on top of all these transactional processes. It's great to act on data and fix things, but what's the root cause? We've got to keep looking at these systems and improving them. And one other little bit I'll just quickly call out. I've listed some end-to-end processes here. The one that I'm particularly interested in is change. And by that I mean if you are going to change the system to make improvements or upgrade components or add new ones, you need a set of processes in this area, and that will be related to testing, communication of change, updating of training materials, and that really, if you're going to maintain a good functioning system, you've got to have those processes working well. Okay, so I have in here a bit of an expansion on the various elements there of data usage. Okay, so now let me introduce this visualization, which we've called the data quadrant. What we do here is we take data quality, and we're going to rate data quality so that we can plot it on the vertical scale, and we're going to rate data usage so we can plot it horizontally. So we have our extremes. Up in the far right-hand corner is ideal best practice, where you have 100% data, it's instantly available, it gets to the right people at the right time, it's a beautiful world, everyone is living in love, peace and harmony, and it would be lovely to get there. Down in the bottom corner, we're in the sort of no data, no comment area. If you can't measure it, you can't manage it. So if we're able to rank and rate data usage and data quality, then we can put our configuration, its baseline current operational value there, and then we can start to think about interventions. What specific interventions are we going to make to try and make step changes in improving the system? And so here we see a couple of intervention points, and what we're visualizing is how that change moves us towards the ideal, either by improving quality, improving usage, or sometimes doing both at the same time. It's a simple thing, but when we have been engaging in our projects, we start talking about interventions, different things we can do, it becomes a very confusing thing. But this helps, as I say, to declutter the way we look at it, and it allows us to think about some other sort of more interesting things and have that conversation. So, for example, this is just food for thought, but we have started to think about an area, for example, of no trust. And this is at what point is the data quality so low that nobody trusts it? We think it's around about 40%, but we're going to try and measure this as we go along. Now, 40% accuracy, I've sat in quite a few of the biochemistry presentations. 40% accuracy would be a terrible thing in medicine, but you don't have to have 100% accuracy to have something that's really useful. And when you look at all the elements that make up our measurement of quality, there are a lot of things that are, there. You may not have complete data, but the data that you're using, if it is accurate, then it can be extremely useful. But there does come a point where your system collapses. Up in the top right-hand corner, I think if you're operating in this area and you're trying to make improvements, it's getting increasingly harder because you're pushing against deep cultural change. And those sort of items are things you really have to look now at the way you train people, the way you treat them and reward them and motivate them. So you're getting into an area that's sort of classic IT change management, where you are trying to overcome people's resistance to change, their concern about job security perhaps. And also, connected systems bring with them transparency, and that's not always welcome. So, yeah, right up in the top area now, you're pushing against cultural issues. So in our projects, because our projects are quite short term, as part of the approach, we are selecting interventions that generally are working in that middle area, so they're things that we can actually tangibly achieve in the time frame and budgets that we have. One last little thing to annotate on here is what we've called a resistance map, and this is an idea that we are going to apply at the end of our projects that relates in a way to sustainability, and that is to say how resistant to change is the system. If we stop working with it, if funding runs out, if we hand over to the in-country resources, we do not want to see a system being unstable, in which case we want it to be resistant to regression, but at the same time, we want to see it not being resistant to change and improvements. And we think we can quantify that by looking for evidence of certain things. So, for example, if you have cultural change being sponsored from the top of the organisation, then your upwards resistance to improvement is going to be a lot lower. If you have provided good training, people know how to fix the systems, there's flexibility in it, you're going to be resistant to regression. So a few little concepts there. I've been popping some dots on the quadrant there to give you an example, but just to reassure everyone that there is a lot of analytics that goes behind that. So when we are running these projects, Mozambique and Myanmar, there is in each of those elements that's evidence-based, coming from program data, coming from site visits and interviews, and the full toolkit really of data collecting methods. And on the data usage side, we are mapping quite extensively the data to the to actions to stakeholders. So there's a lot of analytics that go behind that. The quadrant is a visualization to make it easier to articulate where a project is going and what we're trying to achieve. So our connectivity data utilization projects come in 3 phases. The first phase is this design phase where we go through this approach. The second phase is about implementation, and certainly we are requesting changes to the systems that people are using, so that will involve some software development in those implementation areas, as well as looking at people and process. And then finally, when we close, we're looking to obviously generate the outcomes in reports and generate this resistance map. And so that M&E framework really needs to come out in the phase 2 when you select your interventions, to be really clear about how you're going to measure the improvement at that point. Experiences. This is a collection of experiences from individuals. This is not, unfortunately, the country data, because those programs are still midway, so we don't have the data from them. But I'm hoping that my colleagues will get the same chance to present, possibly next year at the Union, to give you specific data on their individual countries. But this is sort of the experience as we see it. And typically, we are finding that the data quality is about 50% for the projects that we've been involved with over the years. And also, therefore, the typical initial interventions are still about driving up the data quality, connecting more devices, solving various connectivity issues, and also looking at data entry and making sure the reference data is clean. And then once you have that improved base, then you're able to really look at issues of empowerment and usability. And the overriding theme coming from that is, we often think we're better than we are. So there's sensitivity around talking to anybody about their system and identifying shortfalls. So when we look at, we think about a system, we do tend to sort of large it up, if you like. But as we look at all the various elements of data usage and data quality, it nibbles away at that first perception. And so often, yes, we find we're not quite as good as we think we are. These projects take a lot longer to set up. We thought they were 6-month projects. They're at least 12-month projects, mainly because of gaining the correct approvals, data sharing agreements, and the rights to do the site visits. So there's a lot of negotiation and setup at the beginning of the projects. Analysing the data takes a long time once you've collected it. And then, as I say, if you're going into an implementation phase that involves maybe changing the user interface of your favorite connectivity portal project, that can have quite a long lifespan as well, to ensure that things are properly tested and rolled out. Stakeholders are a wider group. I think Patricia covered the stakeholder landscape very well. It is patients, it is healthcare providers, but we need to think about all the suppliers that are in those processes as well, including the manufacturers. And empowerment of the staff ultimately is key. I think the point about whose job is it to action data, and then making sure that the individuals who are acting it actually have a process that supports them is absolutely key. So the active projects that we have going, we're in Myanmar, so the configuration here is with the GeneXpert in the TB space. We're working with System 1. I have to acknowledge Dr. Victoria Harris, who is working very hard there, and also acknowledge Chai, who have given us fantastic support on the ground, both logistically and in terms of introducing us to the correct people and helping us get access to the data that we need. So that is ongoing, and some of the interventions we hope to see some very interesting work in the dashboard area to make those dashboards so much more usable, and to see whether we can drive up the usage based on sort of some radical design ideas in that area. And then Ocean Tobawa, who is working in Mozambique, and now the area here is HIV, CD4 count using the ELAIR device. We have numerous pipeline projects that run across different diseases, including an intervention around mobile phone reading of RDT strips. So I think the point here is that this approach and way of visualizing the use of data, we are now building that into every project we do, because connectivity is not solely about technology. And you can't underestimate the need to ensure that people process and continuous improvement is built in at source whenever you do this work, because that's where a big element of the sustainability comes from. Nearly done. Is that right? How am I for time? So what we're really looking to do in FIND now is to complete these projects and to do country level presentations, so you can see some real data behind this. I'm going to keep extending and developing the approach as we go along. We will be repeating it in our own projects, and we are looking to make that available to the community once we're happy that it's working and it models the situation really accurately. And that's what we're going to do. That is the end of my presentation. However, I think it's now everybody else's turn. Are we doing that now, or would you like to do it later? After all the presentations. Okay. Okay, so I think we'll have some time right at the end of all the presentations to allow everyone to maybe have a go at this themselves. So we've got some bits of paper that we will hand out that have the elements on there and the quadrant, and if people would like to, we can run through that and then see what that generates the thoughts in your mind about your own connectivity services and how good or bad they may be. Okay, thank you very much.
Thank you, Mo. I really appreciate the human element that you bring up in all these projects, because we know on the ground if that isn't there, there isn't a champion for that. It definitely doesn't work. So for our last presentation, we have Vish Kulkarni, who's the Global Marketing Manager with Cepheid. He'll present on the connectivity of their new diagnostic tool, Omni, and also how they're connecting Omni with their diagnostic connectivity solution, C360, and how it'll integrate into the current and existing and future coming diagnostic connectivity solutions.
Thanks a lot for that, and good afternoon. I didn't hear anyone. Good afternoon. There you go. Now we are all awake. My name is Vish Kulkarni, and I'm in the global marketing team at Cepheid. My goal here is to really walk through, okay, I lost my slide here. Okay, there, it's back again. Walk through a little bit, really briefly on talk about GeneXpert Omni and how GeneXpert Omni is going to be helping us out on the connectivity side. Yep. Before we get started, I do want to thank GLI for having me over, and also thank everyone to staying back late in the evening, especially considering the margarita is waiting for you out there. So a quick disclaimer here. Before we get started, let's talk about the workflow. What is the challenge we are really solving for here? Here we have a patient, and the patient definitely goes to a sample center, a TB center, where she provides a sample. And then the sample is batched with multiple other samples. And then it's sort of brought in a van to a core lab or a district lab where the sample is tested for TB. And even after testing, someone has to let the physician know what the result was. And after that, the physician is going to look at the result and somehow figure out where the patient was and somehow try and contact the patient. So as you can see, it takes a little while. And here I'm basically showing few days here, but I don't know how many of you were on Monday. I had a good fortune to listen to a TB survivor, Mr. Abdul Sasay, and unfortunately it took him 6 months to even get diagnosed. So talk about scenarios like those, right? So talk about time to treatment, talk about the patient being in the community, and also transmitting disease to other people. Right? So that's a challenge. Even with the instruments that are close to the patient, the challenges remain. And some of the main challenges are power. You have maintenance, right? You have connectivity, which is what we're going to talk about, which is a big piece of close to patient testing, and also the environment. So our solution here is basically a fully connected GeneXpert Omni. And what we're talking about is an instrument which is mobile, which is going to be close to the patient, and will be connected to C360, which is provided by Cepheid, as well. It will also connect to third-party solutions. It will connect to central labs to provide results, and also provide on-site results for the physician to diagnose the patient right on site, and prescribe antibiotics right on site as well. Okay. So how does C360 work? We'll be talking about a little bit of that. So C360 is a tool provided by Cepheid where we download all the data from GeneXpert Omni and other GeneXpert systems, and it is provided, access is provided to the core lab as well as different institutions to remotely monitor their instruments as well as monitor the test results. We have been talking about data and the connectivity and importance of data, providing interventions, and that's the goal here, is to really provide data, to significant data to the end user so that they can take interventions as needed. Okay. So from C360 standpoint, we have instrument surveillance where they can aggregate and monitor instrument data. They also can monitor disease data. We don't transfer any patient information here. It's mostly the test results, and also system and user management. As we talk about Omni, it's a totally connected system, and what that really means, it's managed remotely as well. So there'll be system and user management as well for Omni. So how does Omni connectivity really work? So we have a mobile device that's connected to an Omni system, Omni instrument, and as an operator brings up a mobile device and starts a test, they can start a test on the mobile device and select an Omni to start the test on an Omni. Basically, stick a cartridge in there and complete the test. As soon as the result is done, the result is available on their mobile device, and they can now talk to the patient and prescribe the antibiotic or whatever they want to do, the next steps. right? And we have C360 admin, which will be providing system and assay updates on an ongoing basis, and as well as C360 analytics, which will be capturing all the system information as well as the patient result information. Yeah. And all the information will be available for the user, for the institution remotely, so they can take interventions as necessary. So coming back to our patient here, we have a mother with a child, with a daughter. She's walking over to one of our test sites, and we have our nurse here, Jabu, who's holding the cartridge. She wants to do the test. And we have the patient here at the site providing a sample, right? The operator takes a sample. Now with GeneXpert Omni, they can actually conduct a test with their mobile device. It's available. The application is going to be on the mobile device. They scan the cartridge, scan the sample, and stick the cartridge in the Omni to get the testing started. As soon as the testing is completed, the result is available on site. So Jabu, who's our nurse, can talk to the patient and basically take the action that she needs to take. And finally, we have an efficient really workflow, right? Instead of spending time between stages for the patient sitting out, giving the sample and really don't know what is going on with the result or where the testing is going, and even the physician really worrying about how to access the patient. Now we have a physician who can actually provide antibiotics right on spot. So the results that are same day, and also the time to treatment now going from 2 weeks, in Abdul-Aziz's case, 6 months to 1 day, the same day, right? So finally, this is my last slide. Finally, the solution, now we have an instrument which is going to be mobile, which can be brought close to the patient, and it's connected. So you have data that's been sent to the central results, as well as provide on-site results for the physician to take action. Okay. Thank you.
So let's ask all the speakers to come back up, and we'll start the Q&A session.